Thank you everyone for being here. So as Megan told, I am sociologist. I've been working on public health since 2010. And I'm Brazilian. I'm working in Canada since 2021. And I am Brazil right now. And today I will present um, our scoping review that was published in Health Expectation Journal, and it was result of a collective work. So I saw my colleagues in Quebec in the screen. Thank you everyone for being here and for participating and with me in this research, in this project. So the presentation today is called Strategies for Involving Patients and the Public in Scaling Initiatives in Health and Social Service, a Scoping Review. And I have no conflicts of interest to disclose. And above all, I would like to do my statement of recognition. So in a spirit of friendship and solidarity, Université Laval pays tribute to First Peoples on whose territory the university is situated. Being at the crossroads of the Huron-Wendat people, the Wabanaki people, the Innu people, the Atikamekw people, and the Wolastoqey people, we honor our relationship with each other. And as well, I would like to make my diversity, equity, inclusion statement. So authors of the review that I will present today are a diverse group of females and males from various backgrounds, including patients, clinicians, researchers, students, and policymakers. They span multiple disciplines, including sociology, epidemiology, medicine, philosophy, psychology, and administration. They hail from countries with different income levels, including Brazil, Comoros, Canada, Togo, Benin, Cameroon, and Australia. So once, thank you very much for everyone that participated in this project. And for today, our learning objectives are describe an appropriate methodology for conducting a scoping review, identify the strategies for involving patients and the public in scaling initiatives in health and social service, and identify knowledge gaps regarding strategies for involving patients and the public in scaling initiatives in health and social service. And for today, the plan is to present to you the context of our review. Once the first of our learning objectives is to know how to conduct a scoping review. I will take some time to explain in details our methods. After that, we will pass to our results, the discussion that we had in the paper, and I will share some challenges that we faced during the process and the next steps. And in the end, we will have a QA section. As I told you, our review was published in June 2024, this year, in Health Expectation Journal. And I thank you, each author that worked to have this work done. And our context is health and social care systems globally face resource shortage and rising non-communicable disease. Scaling effective health intervention is crucial, involving expanding their impact and ensuring equitable access. Involving patients and the public in scaling initiative is vital for relevance and inclusivity. Yet strategies for the involvement are not well documented. I will explain in details each main concept in this review, so don't worry if the context is not too long. In this review, our question was, what strategies have been used for involving patients and the public in scaling initiatives in health and social service? So our objectives, they were to review existing literature on patients and public involvement in scaling, identify strategies for involving patients and the public in the science and practice of scaling, identify and describe the characteristics of these strategies. So, first of all, I will present the overall methods deployed. So we followed the Joanna Briggs Institute Methods Manual for Scoping Reviews, and we used the preferred reporting items for systematic reviews and the meta-analysis extension for scoping reviews, the PRISMA scoping reviews, for reporting data, so to guide the writing of our paper. And we followed as well the sex and gender equity and researcher guidelines when extracting, analyzing, and reporting data for sex and gender sensitive research. We used the progress framework for equity lens, and we had 2 patients, partners involved, and we used the guidance for reporting involvement of patients and the public, the GRIP 2, to report our PPI characteristic and outcome in our review. I will say a lot PPI, what means patients and public involvement. So of this slide, I think that what is important to understand is that when we are conducting scoping reviews or any systematic reviews, it's very important to identify and to use the guidelines, the reporting guidelines, the guidelines that will help us to have an equity lens in our work, and even the guideline for involving patients and the public, because it will help us, it will guide our work, it will ensure transparency, and additionally, there are now many journals that will ask us, there is a condition that we use guidelines, reporting guidelines to publish. And for search strategy, we had a comprehensive search strategies. So we searched all these electronic bibliographic databases. I will not read each of them. And we had no restriction regarding language, publication date, or record type. And we searched from inception to 5 February 2024. In the end of this presentation, when I will share with you some challenges, I will talk a little about this date, 5 February. And I mean, we had to update our search strategies after we submitted. And so I will share this with you as a challenging in conducting reviews. And our search terms reflected the following main concepts: patients and public involvement, scaling, and health and social service. I think that it's important to share with you that, okay, for us, we used the word scaling in our paper, and health and social service, involvement, patients and public involvement, whatever. However, and for our search strategies that counted on the expertise of information expert, we used synonyms to each term. I mean, for scaling, we considered as well widespread, spread, and for example, for patients and public involvement, we used as synonym, cooperate, co-production, and community-based participatory research. So I would like just to show you this example from the Medline Ovid search strategy, because it allow us to know that how important it is to be very large in the synonyms that we use for the keywords. And for the gray literature, we searched 12 websites. They are all there. And following the guidelines on the topic, we retrieved the 100 first reports, but except for one website, that was the SpendedNet website, that is specialized organization on scaling. We searched the whole website, and the search on this website was made in February 2022. So before presenting you our eligibility criteria, I thought that it would be interesting to present our main definitions, the main concepts, and the main definition that we use in our scoping review. And so like that, it would be, it would be easier for you to understand how we operationalize our inclusion-exclusion criteria. First of all, when we are talking about the scaling of health and social innovations, or the scaling in social and health service, we can also find this word scaling as a practice in the literature as a synonym of spread, meaning replication, an intervention, or an innovation elsewhere. So, based on the literature on the topic and our previous work, we define scaling health and social service as a systematic, evidence-informed, and ethically congruent process whose aim is to increase the intended impacts of an intervention or innovation that has proven effective for improving quality and care and the equitable welfare of individuals and population. Sorry. So scaling may also aim to increase the equity impacts, that is, ensure that not just a larger, but a more diverse population has access to the benefits of an intervention or an innovation. And all this perspective on equity, on increasing impact for increasing health and welfare of individuals and population, this is something that progressively, in each of our work, we develop it. And so we like in this review, we used our own definition based on the previous definition published in the published literature, but it's something very original, I could say, from our perspective, how we understand scaling. And for explaining scaling, I always like to work with the metaphor of fruition of McLean and Gargani. This is published in the book. And so let's think that the tree is the intervention and the apple is the impact. And so there are many types of scaling. I don't want to take a lot of time on them now, but what is important is just, I want to show you just two types, and for understand the concept of scaling. So in the first one, in the first figure, we have one tree with 3 apples. And after the scaling, we have one tree bigger and a lot of apples. So if we think in real life situation, we can think on a training. And so we engaged more teachers, more training to train more people. And the other figure, we have one tree with 3 apples, and we have 3 trees with the same 3 apples. And if we think still in a training, we can think, for example, that we implement our training in other cities or other regions, and so in the end we have the same outcome, what means increasing impact. And when we are talking about scaling, the literature will say about phase. So the first phase is the planning of scaling, which comprises the scalability assessment, assess the suitability of the intervention for scaling, develop a scaling plan, what means outline a vision of scaling and a compelling case for action. And we have the step 3, prepare for scaling, secure resource and build the foundation legitimacy for the scaling plan. After that, after we planned our scaling, we pass to the next phase, that is implementing, what is proper scaling the intervention. So implement the scaling plan, making necessary adjustments based on performance data. And in process and in the end, we have the evaluation phase. What means evaluation and monitoring effort during the scaling should be focused on measuring effectiveness over time, rates of reach and adoption, acceptability, compatibility with existing intervention and costs. So it was the main concept for scaling that we use it. Now we breathe 50 seconds because we will pass to the next concept. Okay, the other main concept in this review was the concept of stakeholders. So we defined stakeholders as any person or group with an interest in or a role in a scaling initiative or affected by its impact. What means patients, providers, community-based workers, founders, policymakers, product makers, researchers, and the press. But what does mean patients and the public as stakeholders? We considered patients and the public as stakeholders. Patients or their families and representatives, beneficiaries, civil society organizations, communities, and users. And now we enter in another main concept that was patients and public involvement. So what is patients and public involvement? What do we consider as being patients and public involvement? So we define the patients and public involvement as the partnership that scaling practitioners, like researchers, policymakers, health professionals, establish with patients, citizens, communities, and other civil entities to scale effective health and social interventions and increase their impact. But for this definition, we use it an already published framework. So this is the continuum of involvement, first created by Carman, after improved by the Montreal model, but we adapted this framework for scaling. And so when we are talking about patients and public involvement, we have 4 levels. The first one, we can have patients and public receiving information, but they have no role in contributing to scaling. So it's the first one, information. After that, we have consultation. So patients and the public could provide their views, thoughts, feedback, opinions, or experience, but without a commitment on act on them. And after that, we have the collaboration. So they participate in commenting, advising, ranking, voting, prioritizing, and reaching consensus on scaling, but without direct control on direction over directions and decisions. And the last one, what we consider as the stronger way of partnership with patients and public involvement, we have the co-production that occurs when patients and the public will have the same power of decision of the scaling team. They are considered as equal members of the team. And for real life situations, I like to think, because it's not clear when we read the definitions, it's not clear the difference between consultation and collaboration, or even collaboration and co-production. Personally, I like to think information, okay, people have no active role, they are receiving information. But I like to think that in real life situations, the consultation will occur when we go on, we're looking for populations, patients, and the public in a specific point, in the specific moment of the project, to have their feedback on a specific topic. When we pass to collaboration, I like to think that, okay, we have a steering committee, for example, an advisory board. We are collaborating, we are participating together in many meetings, but we don't have patients and public, they are not allowed to decide. We will not consider they will have no power of decision. We consider what they are saying, but they are not the power of say no, I'm not agree, so we have to look for a consensus. And the co-production is when we consider patients and the patients and public input and feedback in each step, and in a meaningful way, in the sense that if your patient's partner will not agree with something, we have to discuss together and have a consensus. We will not just pass for this. And for the main definition, for the last one, we have PPI strategy. So we consider PPI strategy as an approach to sustain patients and public involvement in scaling initiatives that may be occurring in scaling science or practices. The goal of a PPI strategy is to enable patients and the public to receive information, advise, collaborate, and co-construct the scaling of an intervention. But strategies require methods in a way of enacting this approach. And so for identifying PPI strategies, we base it on Manier framework. It's not a framework by Manier, but Manier published a systematic review on patients and public involvement in mental health. And so this review used the Karman framework and the Montreal model framework. And so this review identified 27 PPI strategies. So we used these strategies as a starting point. And as you can see in the figure, we have these strategies across 5 levels of the health system. So the first one, we have the direct care. The second one, we have the organization of healthcare. After that, the professional training. After that, research. After that, policymaking. So, and each level of the healthcare system, we have many strategies. And these strategies, they could be more or less. We can engage, using these strategies, we can engage more in the sense of the co-leading, the partner, or at least in the sense of just informing or consulting. So we use that as a starting point, but we produced our own definitions on what we mean PPI strategies in scaling. So here I have an example. We defined the policymaking level when the scaling initiative may occur at the policymaking level, where patients and the public participate in developing, implementing, and evaluating system level scaling policy and priorities. So for the strategy population consultations, we provided a definition. And after that, we provide a method, because for our scoping review that we aimed to inform people of what they would do if they want to partner with patients and the public in scaling, we had to explain, and we had to provide data on how to do that. That's why have the methods for each strategy was important. So now, finally, we arrive our eligibility criteria, now that we have already known the main concepts. So for population, we consider any type of stakeholders involved in PPI strategies in any phase of scaling health and social service. So they had to include patients and the public overall as stakeholders. For intervention, we consider any strategy proposed for involving patients or the public alone or with other stakeholders in scaling initiatives in health and social service. And we included both studies with comparison groups and studies without. For outcome, we consider papers with at least one of the following PPI outcomes impacting on involved patients or the public participants themselves, or services provide an impact on the organization or system, influence on the broader public and on population health generally, and aggregate outcomes. And in the paper, we provide the reference that we used for these outcomes. And finally, as study design, we only excluded with ground publications, reviews, study protocols, editorial material, opinion tests, non-authored records, non-traceable appendices or parts of documents, and video or audio records and presentations. We did not include the reviews in this review because it was very hard to have access to the primary data in these reviews. For selection process, we used the EndNote for reference management and duplicate removal. We then exported the titles to the Covidence platform, and we operationalized our inclusion criteria using questions based on our people's elements that I presented before. And we piloted the screening using a random sample of 5%. And we proceed in all the process, selecting, analyzing, and extracting data with paired independent reviews. And doubts and disagreements were resolved through consensus between paired reviews and, if necessary, a third part. And the reasons for exclusion decision regarding inclusion were recorded in Excel. And for data extraction, we extract data on the biographic characteristic of scaling initiatives, title, description, country outcomes, level, target level of care. I will not take a lot of time here, because when I will be presenting the results, all the variables that we extracted will be there. And for the characteristics of PPI strategies, I will concentrate myself in one variable that we extracted that was a novelty, is that the ethical reasoning for PPI. And here it's a novelty in the domain of scaling, because we had the luck to have a philosopher in our teams. And so when we started this review, we found interesting looking for why author, what are the justifications that author gave for the patients and public involvement. I mean, why people are working together, why researchers, decision makers are working together with patients and public in their projects. And so we used theories of the philosophy to understand that. And we have two main theories. The first one is the goal-oriented, so people can be partnering with patients and public because they want to increase their scaling effectiveness, or because they want to consider patients and public values in the scaling. In the other hand, in the other way, people can partner with patients and the public because they consider that it's important and imperative that to do that. It's a duty and right. And people can use all this justification, can give us all this justification in the same time. And we use the GRIP2 for quality assessment of the PPI. For data extraction, we used the Excel for pilot and paired independent reviews, data extraction of confidence, for quality assessment on PPI reporting, we had as well the GRIP2. So in the review, you can find in a supplementary file all the elements that we use it for accessing the quality of PPI. It's not the quality of the study included, it's the quality of the reporting of the PPI. And for data analysis, we used the Prisma flow diagram for selection process, and all the details are in the review as well. So finally, we arrived in our results. We found 110 unique reports, but there were associated reports. So we have a total of 120 reports included in this review. For distribution per year, we noticed that in the last 5 years, we have an increase of 145% in the publication on PPI. And for the characteristic of the scaling initiatives, now we are still in the scaling level. We are not entered in the PPI strategy. They occurred mostly in the high-income countries. So they were created mostly for other stakeholders, but we had 27 scaling initiatives that were created with patients and the public, and 5 that were developed just for patients and the public. They occurred mostly in community-based primary health care, and for the health and for the target health and social issues, and they target it was a balance, but they target mostly populations, specific population like maternal and child health, and child and adolescent health, infectious disease, and health interventions. What means health, palliative care, decision aids. And for the setting, they occurred at mostly in community settings, and the big part did not report on sex and gender sensitive scaling. So we found we found 23 strategies of our STAR framework and used 236 times. So the level were the level in which people were most engaged was in the direct care level, and the PPI strategy was patients and public education. The second level was the level of policy making, and the strategy was population consultations. So in the beginning, since we used the framework with 27 strategies, we didn't find 3 strategies. So we found 24 strategies, sorry. And so we found 23 strategies and not 27. And for the continuum of involvement, and I will take just for 5 minutes to finish. And for the continuum of involvement, and patients and public were mostly involved in collaboration level. And for the scaling phase, it was not mutually exclusive, what means that we consider in the same project, patients and public may be involved in the planning phase and the evaluating phase, in the planning and the implementing, or if not the implementing and the evaluating phase. And so we found that mostly patients and public were involved throughout the 3 phase, the whole process of scaling. For the ethical lens, we found that the justifications given by the authors was mostly goal-oriented, what means that they worked with patients and the public aiming at increasing scaling effectiveness. And now we have our knowledge gaps on the domain. And for the type, overall, we notice a lack of practical information on how to work with patients and the public. And I will present to something like that. And for the type of incentivation, so how can we compensate and incentivize the participation? The big part did not report it, how they did that. And they did not report it as well, and how to recruit patients and public. And they did not report it. When I said they did not report it, I am saying that the big part of the included reports, they did not report it. And what were the frameworks or guide that they used to work to engage patients and the public, or if they did it? And for the patients, for the PPI outcomes, we have very good outcomes. So the literature will say us that we had good outcomes in good results working with patients and the public. But yet for overall cost effectiveness, what involves all the practical steps, the practical tips on how to do it, we didn't find a lot of papers reporting all that. And they did not report sex and gender sensitive PPI strategies. The progress factors were very, very, very poorly reported. And so we really need to move on excellence and in this topic. And we found that they poorly reported a definition for PPI, what they consider as PPI, and they did not present a PPI theoretical rationale. So we have substantial number of reports included. As I said, we had the increase of 144% in the last 5 years. This reveals rapid progress on evidence on PPI in scaling. However, if you look on the Prisma flow, we will see that a lot of papers were excluded because they were on scaling, but they did not involve patients and public. So guides and frameworks was mostly found in the gray literature, what may indicate that the frameworks say that we have to do that, but when we look in the published papers, that normally will express a project that was done, we have list. And while our recent umbrella review on scaling found the scaling mostly occurs in low and middle-income countries, the patients and the public involvement in scaling is mostly occurring in high-income countries. This may be because this movement of patients and public involvement is raised in North America and Europe, but also maybe we are not looking for the good words, the good keywords, or there is a lack for qualitative research on Global South, on low and middle-income countries to understand what are the kind of practice, the ongoing practices. And Fear Scaling Initiative provide a definition of PPI, and patients and public are increasingly involved in all phases of scaling, but co-production, what is the most involved form of PPI, is not well established as a practice. And so for sure there are specific needs and efforts to co-production. And I will stop here and go to the Q&A section because I am so sorry I passed 60 minutes for the time. Thank you.
No problem. Lots of time. So thank you so much. I see Linda Hunter put a message in the chat that she had to run to another meeting. She is also presented Keita Canada here. She's fantastic. So thank you so much. If anyone wants to ask a question, you can raise your hand or put it in the chat. I do have a few, and sorry, I'm getting over the flu, so I'm a little coughing at my end. It was a bad flu this year. But I have some questions to start us off. So some of these were sent in with people when they registered. So the first question from the audience member was, a challenge that I'm curious about is the criteria for evaluation and exclusion and inclusion. Is it obvious when a paper should be included in the scoping review, or are there some exceptions that need to be made from time to time?
Okay, this is a very, very, very good question. And exceptions should be made from time, because it's always important. Once we have published the protocol for the review, ideally we should not change our inclusion and exclusion criteria. However, we will change mostly of time, and it's important to better frame what we understand as the phenomenon that we are looking for. For example, in our case, patients and public involvement, our criteria of exclusion and inclusion did not change. However, what changed was our perception, and we better frame it. And so we included the definition and the need for a method, because when extracting data, we perceived that, okay, we had papers that say, oh, we are doing patients and public involvement, but to inform our readers, they did not provide details on patients and public involvement. So we returned to our selection. We did not change our inclusion and exclusion criteria. What we changed was our perception. It's like we better frame our definition of PPI. Okay. It was clear.
Yes, thank you.
Okay.
And I'm not sure the person who submitted that question, I'm not sure if they're with us today, but we usually, with your permission, we usually post these on our YouTube channel. So if they can, the person can always follow up with the recording to get their answer. And I see our colleagues in Quebec have a question, so please go ahead.
Hi, I'm here.
Hi.
Just to stay close to the mic. Congrats, Roberta. It's a great presentation, and I would like just to, if you can clarify a little bit the last slide about the challenges, because you don't have time to explain, but you can.
Okay.
The challenges, because I think it's interesting. Thank you again.
Okay, and I think that the next slide on challenges may cover the next question. I will just share my screen. Give me just a moment. Okay, so the challenge working on scaling size, it's really the work with the definition of scaling, because we have like scale, scale up, spread, and we have like implementing in large scale. Does it mean scale or not? So as I said, framing PPI was difficult as well. It's like, because scoping, we used to conduct a scoping review for new domains. So that's difficult as well, because we are creating definition, we are trying to frame the phenomenon, and we faced as well the lack of details on patients and public involvement. And we had the big challenge of time, because scoping review, doing a systematic review takes a lot of time. And when we finished our review and we published it and we submitted and we had the feedback, reviewers said, oh, it's an excellent review, it's very, very good, but it's recommended to update the search strategies. So we struggled with time to conduct a review, a high quality review in short period of time. Thank you.
Excellent. Thanks for that question. So another one from me. Sorry. How have patients partnered up front with your project? So I'm not sure, you might have covered this a little bit already, but just in case, how have patients partnered up front with your project in co-development and co-leadership?
Okay. I think that the main difference between co-leadership and collaborating is the pounds that we will give to the decisions of patients and public members. And so in each step, for example, Kati Kastner, the patient partner, she really, we were thinking on not consider only papers with outcome. And she said, for me, it's very important to know what is the outcome. And so we consider this decision. That is the first point, I think. We can say that we are co-leading something or co-constructing something when we are not partnering just to do a check, but we are really consider what people are saying, and we are making decision based on what they consider as important. And there were different moments and given feedback on the research protocol and the inclusion-exclusion criteria, presenting the results with us. Kati as well, she was with me when I presented this review on NAPCRAG, and co-authoring the review as well was important. And so it's to build confidence, and it's not about how much time we will spend. It's also about that, but it's less about time and more about consider the patients and the public as an equal member of the team.
Perfect, thank you. Couple more, we have a few more minutes, so I'm going to keep going. Would it be possible to make recommendations on PPI involvement in scaling after this review?
Yeah, in parts, because I will share the screen. First of all, it's possible to make recommendation. It's possible to inform people once we provided, I will show you something. For example, once we provided a definition for each strategies, so someone who is looking for a partner with patients and the public could read these definitions that are based in real life situation and inspired themselves to proceed with a strategy. And once we found knowledge gaps, we made recommendations for the next research. What means it's important to report and to looking for register the types of incentivization, how people are recruiting, and what type of involvement framework they are using. As we saw here as well, it's important to report equity factors, progress factors framework. So this is the type of recommendations that we are able to make after this review. But to go further, and is the next step of our project, we are conducting a scoping Delphi study. So we will ask experts and patients and public representatives to access the strategies that we found for equity, comprehensiveness, significance, and adaptability. What means? We will ask them for each strategy if this strategy is relevant for engaging individuals across the diverse ethnic, gender, and health and socioeconomic backgrounds, if the strategy could be applied across all scaling phase, if the strategy is adaptable for different contexts in high-income countries and low-income countries, if the strategy fosters meaningful engagement of patients and the public, and to suggest other strategies. So the next step of this project is really produce a list of recommendation PPI strategies.
Okay, excellent. Exciting.
Yeah.
And one more. I think we have time for one more. Are there any tools to help scaling teams who are partnering with patients and public?
Yeah, it's a tool produced by our team. And so this is called Innovation Scalability Self-Administrated Questionnaire. So we developed this tool in a very systematic way. We did systematic reviews to find all the existing tools with the aim of assess the scalability of health innovations. And so we access all the tools that we found, the items of the tools that we found And we asked the patients and public and researchers and policymakers to access the items for relevance, for necessity, and for clarity. And so this is a patients oriented to work with patients and the public to planning the scaling. It's available in the site web. I will put this in the chat for who wants to know more.
Perfect. Thank you. That looks super handy. Okay, well, I'm going to wrap it up now. So thank you so much for the presentation. That was fantastic. And I'm going to follow up with everyone with the evaluation link. I'm just going to send it over email. So please, we would appreciate everyone doing that. Our next webinar is actually going to be in February. We're taking our January presenter had to reschedule, so we'll be taking a break in January, but we hope to see everybody back in February.
Thank you, everyone.
Thank you. Take care. Have a wonderful holiday and enjoy the rest of your time in Brazil.
Thank you. It's hot now.
I know. I'm jealous. I'm very jealous. Take care, everyone. Bye-bye.
Bye-bye.